make a plea at the very beginning. I'm very old-fashioned. I would very much like to get through this presentation and then take questions. I get to be old-fashioned because I'm old. I was born in 1944, which means that I'll be 73 on my next birthday. And as a consequence, as someone who's had a rather interesting, somewhat checkered career, I'm going to try to make a couple of points that were neatly presented by our excellent presentations, the excellent presentations you just heard. And I want to pay particular attention to the ways in which what I'm going to describe as a problem associated with the criminal justice system, specifically in the form of mass incarceration, has distinct neighborhood effects. Those neighborhood effects have a great deal to do with driving health disparities. And I'm hoping that at the end, when I'm going to show you a video, that you'll not only have a number of interesting hypotheses that you yourself might want to generate in your own research on issues of health disparities, but I'm also hoping to recruit some of you into thinking about the roles that you can play in dealing with these health disparities, not so much as researchers, but as educators. April of this year marked my 30th year doing research in HIV/AIDS. I'm not an epidemiologist, I'm an educator. But as a way of understanding health disparities and something that has dominated epidemiology in the United States for the last 35 years, I want to really look at the ways in which the HIV epidemic, one of the primary health disparities that we describe in the United States, is driven by a set of social factors that have a distinct impact on one particular race, ethnic group. And those of you who are accustomed to reading the statistics on HIV are aware of the fact that we're talking about an epidemic that started out appearing to be something that was especially impactful for one particular community, men who have sex with men, but which over time has morphed into something that, as of the last statistics from the Centers for Disease Control, involves roughly 50% of all new cases of HIV being located in the black community. We just, June 5th, celebrated what we often describe as the 35th anniversary of the HIV epidemic, but as many of you know, as I hope all of you know, what we're really looking at is not something that began in 1981, we're talking about something that had its onset at least 10 to 15 years earlier. Think about it. That MMWR article that described Kaposi sarcoma in a group of gay men in Los Angeles was obviously describing the end stage of HIV disease. We weren't looking at people who had just contracted this infection. We're looking at folk who were so far into the disease, most of them were on death's door. And if we understand HIV to be an infection that is largely asymptomatic and doesn't even show up until you have an AIDS-defining condition, isn't it clear that the real beginning of the epidemic wasn't in the 80s, but in the late 60s? What happened back then? I teach students who, for the most part, weren't even born when I started my time at Columbia University. And one of the things that I worry about as an educator is how little American students understand about history. Some of you are nodding. Can I get an amen from the audience?
Amen.
So everybody kind of knows that Richard Nixon was an interesting guy, that he's often described as one of those examples of the presidency gone bad. And there's a lot of Nixon talk now that we're struggling with a candidate whose name shall not be mentioned at this podium, but who's giving us some real pause to think about ways in which public policies have a great deal to do with driving the social conditions that we identify as especially important in understanding health disparities. I want to suggest that one of Richard Nixon's most important contributions to this particular lecture, this particular conversation, had everything to do with a speech he gave in 1970, when concerned about all the young people who were tuning in, dropping out, and taking drugs. He declared drugs as public enemy number one. In 1973, with the formation of the Drug Enforcement Agency, we started a war on drugs. Now think about the logic of a war on drugs at that point in the 1970s. I'm suggesting that HIV was already present in our midst. So this was a public policy that very successfully locked up the group that was at greatest risk for being exposed to that virus. I want to suggest that a couple of things happened as a result, but the most important was this war on drugs was a decision that we made as a nation to deal with issues of drug dependence and addiction, not as a medical, not as a public health phenomenon, but as a criminal justice issue. So instead of treating the problem, air quotes, we decided to lock it up. And here's the result. We are, as many of you know, 5% of the world's population, but as a nation, we incarcerate 25% of the world's prisoners. Say it again. 5% of the world's population, we account for 25% of all the folk doing time behind bars in the world. 1972, there were 200,000 men locked up in state and federal facilities of incarceration in the United States. By 2010, that number had grown to 2.2 million. Now again, me in history. Joseph Stalin, of all people, had an interesting observation that I think really fits. He said, one death is a tragedy. 1 million deaths is just a statistic. So it's often helpful for folk who deal with numbers and with quantitative concepts to focus on images. This is what this looks like. This is our democracy. As is this. Or that. So what are you looking at? That's what you're looking at. 68% of all the folk who are locked up are men of color. I'm excluding women for the moment because they still make up only roughly 11% of the incarcerated population in the United States, which has significance. But for the moment, I just want to focus on what this does with men. This is an issue of social control, is it not? It's social control not just because these are people who are away from the community. It's social control because, more than anything else, when they come back, they're no longer members of our democracy. They're no longer citizens like you or me. They can't vote. In many states, they have no access to educational opportunities. In 1994, the Congress, in its infinite wisdom, suspended Pell Grants for folk who are doing college courses in prison. So in a population where 68% of the folk who are locked up did not finish high school or are functionally illiterate, the moment you say you can't have access to further education, we're really looking at a driver of second-class citizenship. HIV/AIDS. This is the notion that we really did quite severely impact the epidemic, because if you look at that bottom number, in 1997, roughly 1 out of every 4 persons in the United States living with HIV/AIDS passed through a prison. And let's be clear about the relationship between prisons and jails. They're all related, but I don't want to make the assumption that because we use jail and prison interchangeably a lot, that everybody's clear about what that means. A jail is a place where you're arrested, the cops take you, you are held in a facility until you are brought before a judge. Depending on whether or not you are charged, go to trial, and have a conviction or decision of innocence. It's the primary stage that begins this process of social disadvantage that I'm alluding to here. And are we clear about how many Americans that works out to influence? Every year in the United States, 12 million individuals are arrested and will do at least a night in a jail. If you look at all of the Americans over a period of 10 years who have gone through some kind of interaction with the criminal justice system and the cops, the number comes out to close to 100 million. understand that we are a carceral society. A significant portion of our social policy is driven not by our ways of thinking through legislation. They're driven by these kinds of interactions that dramatically affect one's social status, and in affecting social status, by implication, it's also affecting health. Nowhere is that clearer than with HIV. But to connect this to the previous presentations, let's be clear that we're not just talking about individuals. We're also talking about the neighborhoods, the communities where they're from. I've been working with HIV/AIDS in New York City since 1990. And it's sort of interesting to understand that in the state and in the city, that right now serves as the epicenter for the epidemic. Between 15 to 17% of all the cases of AIDS reported to the CDC since the beginning of the epidemic have been in New York City. It's interesting to see how this phenomenon, mass incarceration and HIV, plays itself out. There are 68 prisons in the state of New York, at least there were in 1990. Those prisons held 25% of all the folk incarcerated who were living with AIDS in the United States. And it's important to understand that in this very large state, it can take 8 hours to go from one end to the other. 7 neighborhoods in New York City supplied almost 3/4 of the population doing time in these facilities. And what's even more important is the degree to which those 7 neighborhoods, more than anything else, had the highest rates of HIV infection, in some cases in the United States. Mont Haven, 3.5%. 3.5%. 3.5% of the adults are living with an HIV infection. If you were to link some of the neighborhoods that had those rates of infection, you'd be looking at a system, a conglomeration that would have HIV infection rates that rival many of those that we see in sub-Saharan Africa. Another way of understanding this as a neighborhood phenomenon, everybody loves maps in New York. These are $1 million blocks. I love that concept. What's a $1 million block? If you were to go on the block, get the names of all the folk who live on that block who are currently doing time in a prison upstate, we call that doing a bid upstate. And then you added the amount of money that the state was spending to keep those folks locked up, you'd come up with a figure of $1 million. Those are the numbers of $1 million blocks that we have in New York City. And here's how they map onto health disparities. We're not just talking about HIV/AIDS. As a driver of inequalities, mass incarceration is probably doing more to underscore our ability to understand and explain health disparities than just about any other social policy. There's another way of looking at it. This is from a New York Times article that came out April 20th, 2015. 1.5 million missing black men. For every 100 black women not in jail, you're only going to be able to find 83 black men. And your memories aren't so short that you have forgotten Ferguson, right? In Ferguson, Missouri, for every 100 black women, you can only find 40 black men. They're either dead or they're locked up. Understand that when you do research that looks at race, ethnicity, be careful and be sure that you're not just simply looking at a domiciled population. Because the folk that we don't count who are in these institutions, were they to be included in a lot of our social science statistics, would indicate that the rate of high school completion in the United States is a lot lower than we imagine. We're not counting them because we don't see them. We're not counting them because we have no real direct contact with them. But they are there. And the degree to which they're missing, I want to suggest, has a great impact on the health of neighborhoods. Name one nation anywhere in the world where you can take 50% of the adults out of the community and expect the kids who are left in that community to have normal lives. Can't be done, can it? I want to suggest that what you're looking at here is not just missing bodies. You're missing one of the most important constituents of neighborhood life. Human beings, as creatures, got together and became socially driven because of the benefits that it basically brings to the children who are the future of the species. Take away the adults, take them out of the picture, and you're not only creating social chaos, you're creating a situation in which, at least in the neighborhoods where I work, a lot of the kids who have never had any real contact with their fathers believe that it is their lot in life to join them. What happens when, after a couple of generations, it becomes normative in your neighborhood to expect that you too will be doing time in prison? What does that do to the education system? What does that do to folk who are going to have a difficult time accessing health care because having been away for so long, they no longer qualify for many of the benefits that make health care possible? So, I don't know about you, but I've been teaching for a long time. My first classroom experience was in 1964, 52 years ago, in a freedom school in Holly Springs, Mississippi. I was one of those folks who was heavily engaged in the civil rights movement. I was a field secretary for the Student Nonviolent Coordinating Committee, SNCC, which 30 years ago had people going, ooh, ah, and right now has my students going, what's that? One of the things about education in public health, as a guy who did not start out as a public health professional, is to note how much of what we do in the classroom is all about telling people how to describe, quantify, and put perspectives on problems. The difficulty is that because we're so focused on problems, we're not really that clear about solutions. So a lot of people, a lot of your students, probably find your classes to be depressing because they have ways of putting numbers and figures and charts around all the things that are going wrong. And when somebody says, well, what do we do to make things right? They go, well, that's an object for further study. So I want to have this talk be one where I'm focused not just on describing the dire nature of the impact that mass incarceration is having on the nation. I also want to talk about ways in which we can not only think about solutions, but those solutions can ultimately involve you. For the last 6 years, I have been teaching in the Ballard Prison Initiative. Some of you may have read about this in the newspapers. One of the places where I lecture, Eastern New York Correctional Facility, has a debate team. The debate team beat Harvard in a debate. Really quite remarkable because it's sort of a way of describing how much it is the case that some of the best minds in the 7 neighborhoods that I described earlier are not in the neighborhood, they're in prison. So if you have this raw intellectual potential and you're trying to figure out what are we going to do with this when many of these folks go back to the community, how are we going to manage their lives when educational opportunity is so restricted? The answer is, what if we return higher education to prison, find the individuals who are really able to do something like beat Harvard in a debate, and then, if anything, make them public health specialists, and in some instances, epidemiologists. If you read that piece about Harvard and Ballard, and you wondered, how was it that these guys beat a team from arguably one of the most important educational institutions in the world, not just in the United States? They never did say what the debate was. Let me be the first to sort of enlighten you, because it's a way of describing what you're going to see next. The Ballard team was asked to debate the affirmative. The United States as a policy should permanently bar from any educational opportunity children who are born into illegal immigrant families, families that are here illegally. They were supposed to argue for that position. Deep, huh? How would you win if you had to argue that position? Here's what they said. We know more than anything else that public education in the United States sucks. The most damaging thing you could do would be to expose children to a system of education that routinely creates disadvantage. It's a good idea. No, give them something better. They won. Knowing that you had that kind of manpower, person power, staff power, we started doing a public health concentration in 3 of these facilities: Fishkill, Taconic, which is a women's facility, and Woodbourne State Correctional Facility. The idea is public health, interestingly enough, is what we call a felony-friendly work environment. Yeah. See the Affordable Care Act? We're trying to get more folk to sign up, to have access to health care, not have the emergency room in many of these communities be the primary care provider. Let's have people sign up. Let's have them have yearly checkups. Let's see if we can't catch conditions that in the emergency room have gotten out of control and get them early. When many of the neighborhoods that these guys are from, to which they'll return, 40, 50, 60% of the adults there have a history of involvement with the criminal justice system. They tend to stay away from clinics and hospitals. They don't like having to explain to a receptionist why in their medical records 10 years, 12 years, 15 years is missing. Because their experience is the first time you say to somebody, I did a bid upstate. Yeah, I got busted for a B&E, breaking and entering, so I wasn't around for a while. Then you see the look in the eyes of the receptionist. Suddenly the light goes out, and you're no longer feeling as if you're being treated as a person. You're now something else. And folk will tell you, I would rather die than go back to that setting and endure that kind of abuse. My guys are the ones who turn out to be your community health advocates, your community health outreach workers, your patient navigators. They bridge an important gap between folk in the community who have stopped trusting medical science and clinical facilities and the facilities themselves, because they're also charged with the task of helping to civilize medical care personnel so that they start treating their patients as patients and not as objects. So, it's a way of saying that a public health concentration in this kind of setting makes a lot of sense. All right, now here's where we get tricky. I hit escape.
The PPI program first started at Eastern. Approximately 15 years ago, I was there.
Can you?
Yes. When the PPI program first started at Eastern, approximately 15 years ago, I was there. And I remember some of my friends getting accepted into PPI. I used to see how happy they were to be a part of something meaningful.
It changed the whole scope of my incarceration from wasting countless hours a day, doing things I shouldn't have been doing, to giving me something to focus on and concentrate on and put my all into.
It really hit me that I had to do something, not just so I don't repeat the same mistakes, but so I can contribute to my family, first and foremost, my family, and my community. Because I think those are the people who I really need it most, especially since I've been a contributor for the negative effects of our society.
What if the solution was the person we thought was the problem? I want each of you to think about the moment you decided to stop sliding, to stop failing, stop moving sideways, and to rise. You've overcome significant hardships. Some weren't your fault, some were. But the measure of your achievement is the distance that you've traveled since then.
My time with Ballard has definitely showed me that I am an intellectual. I like scholarly work. I love it. I get enthused by it. I get lost in a new book every time I take it back to my cell and read it. And I look forward to just the pursuit of education and acquisition of knowledge in itself.
I was released November 15th of last year. Ballard College actually helped me transition into CUNY very easily. And I'm on the fast track to get my bachelor's by the spring of next year. I mean, great route.
This is an investment that the entire nation should be making. These guys are going to be problem solvers, and they're going to go back to places where problems abound. The notion that they have a sense of what to do and how to do it, I think, bodes well for the future. At my age, for the first time in a lot of years, I consider myself to be an optimist, based entirely on what has happened to me here.
Others will tell you how significant our program is, and there's an emphasis in how much we do for you. You ought to know that you do a lot for us. We live at a time where people don't really believe in education. That doubt is something we struggle with. Your enthusiasm, your determination, your idealism about education gives back to us a reminder of why we should fight for what we do.
When I saw my family and I saw the tears and the excitement in their eyes and the words of inspiration that they were giving me, it was like, that's when it really hit me. That's when I just couldn't hold back anymore. There was just tears coming down my cheeks. And it was a really amazing experience. And I've actually never before I've cried any tears of joy like that before. And it actually made it possible today. Yeah.
I believe we don't have a single person to waste in this country. And when you look in the mirror, if you still see a person who's the problem, then consider what if the person we thought is the problem is actually the solution? What if the solution is you?
I always wondered what it would feel like to be the best in this world. Well, some of the best in this world are here today, and they're my fellow graduates. Some people refer to us as inmates, prisoners, con men, but we are more than these labels suggest. This education, this degree, symbolizes excellence. Excellence as a birth out of struggle. My struggle, all of our struggles.
Rich Camara, the guy who said he's been fast-tracked to get into CUNY to finish his degree, is now in his second year as an MPH student in epidemiology at the Mailman School of Public Health. 3 other of the students that I've taught at Woodbourne are now graduates of Columbia, one with a graduate degree in social work, another a graduate degree in epidemiology. And these are the guys who are basically inspiring the folk I see every Monday when I go give my lectures. Interestingly enough, 90% of them want to be you. They want to be epidemiologists because they understand that something about their experience, when translated and articulated as a series of hypotheses about life and health outcomes for folk in the community, they're very aware of the fact that you have the key in this field to help them make sense of what for them are key questions in their lives. So this is more than just a way of thinking through how do we structure the research that helps us understand the impact that this is having on health disparities and other health outcomes in the United States? It's also something that I think has dramatic impact on the future of the country. Here's a way of understanding it. It costs the United States $60,000 a year on average to keep an inmate locked up. The return on the investment is dismal. The Bureau of Justice Statistics last year did a study that suggested that after 5 years, 77% of all the men who were released post-incarceration came back to prison within 5 years. 77%. No return on the investment at all. Governor Cuomo of New York gave a speech 2 years ago in which he pointed out that in the state of New York, where that $60,000 a year gives you a roughly 45 to 50% recidivism rate, if you compare the amount that it costs the state to run that program, $5,000, the recidivism rate for those college graduates who earn a degree on the inside is 4%. A lot of states are struggling to balance their budgets, and they're really trying to understand what to do with a high bill for incarceration that not only is draining tax dollars, it goes directly to the dollars that are used to finance you, your institutions, and in some instances, your research. This is the classic idea whose time has come. It's not just an interesting set of hypotheses to research. For those of you who got into public health, not just because you wanted to do the research, but because you wanted your research to make a difference in the health of the communities that you're studying, think about this as something that in your state, in your setting, might be a way in which you can turn your research into something that has a dramatic, measurable, concrete outcome. It's worth your consideration. Thank you. Questions? Or you're just going to go to break? Yes, please.
That was a undergraduate? It was a
Yep.
college degree?
Yep.
What was the field?
What was the field?
Yeah.
The degree?
Yeah, the degree field.
The degree, there's a liberal arts degree, public health concentration. You don't get an undergraduate degree in public health. This is a major,
Okay.
which is why a lot of folk will go out do another year in one of the city university institutions in New York because they too have basically banned the box. They're no longer worried about a history of incarceration as something that keeps you out of higher education. So they've become a major feeder for us in terms of finding folk who have interest in pursuing graduate study in public health. Yeah.
So do you find that they face similar employment challenges as other college graduates across the nation?
Or yes, they do. They do. In some instances, those who have focused on public health are finding, once again, that public health, especially in the city of New York, is much more interested in figuring out how it can be, how that individual can be incorporated into some of the neighborhood level programming that they've done. So it's of interest to a lot of my students on the inside, literally because they see that as one of the clearer paths to not only getting a degree, but finding employment once you're out. People are interested in these students. And I think you discover, once again, that if you're in an area where you've got large numbers of folk who are right now about to be recruited to sign up for the Affordable Care Act, the whole question of how much men and women with this kind of training could assist in those efforts and could even help drive some of the more interesting hypotheses about the relationship between what goes on in the neighborhood, how neighborhood activity, neighborhood interactions affect health. These are the folk who are thinking through the models that would help us explain and make more concrete some of the ways of describing a set of rather vague neighborhood effects and making them much more concrete, and as a result of making them more concrete, hopefully making them more measurable. Yeah.
Enjoyed your talk as well. I have a question about with new legislation removing, like I'm in Louisiana, but removing on job applications the box where you have to check.
Yeah, we call that block the box.
Right, and so are there those roadblocks for college applications and admissions? Is there something that we need to pay attention to, or how is that across the nation or many universities and colleges? Are there boxes being checked during the admissions process that then people have to score by, or people look at that might prevent some entrance into colleges or disparity looks at the application?
Ballard, in its effort to take what they do nationwide, has focused exactly on that issue. And I'd love to say that colleges and universities are embracing this because they see the moral and ethical dilemmas that are present there. They see it as a kind of an imperative. They're interested because last summer, President Obama instructed the U.S. Department of Education to reconsider Pell Grants as being applicable to colleges, for college students who are on the inside. So a lot of institutions are interested because it's a new source of income. I'm okay with that. Any means to achieve that end. But Columbia, for example, is yet another institution that's really sort of gone out of its way to try and remove that as a barrier, so that there is now a program in its School of Continuing Studies that specifically targets folk who are getting out of this system, saying, yes, we're interested in having you go from an AA to a BA degree, if that's what you do. Bard offers both an AA and a BA on the inside. And one of the more noteworthy members of the Faculty of Social Work, Kathy Boudin, does anybody know that name? Yeah, goes back 50 years. Kathy Boudin was part of the Weather Underground. She was tried and convicted of murder for the killing of 3 Brinks armed guards in a robbery that went bad many years ago. She did 27 years in Bedford Hills Correctional Facility, was released, got a PhD from Columbia, now teaches on the faculty at the Columbia School of Social Work. For the last 5 years, she has sponsored, along with a group of us throughout the university, a conference called Beyond the Bars that has annually attracted roughly 1,000 to 1,100 Columbia students each and every year, because there's a real interest, at least in that institution, in understanding how, as a driver of social inequalities, something can be done about rethinking the ways in which we manage our system of criminal justice. So there's a lot of interest in it. I think it's growing. And now that the profit motive, I think, is going to be a part of why a lot of colleges would be interested in this. My suspicion is that in the next couple of years, some of you may be having a dean call you up and say, so we're thinking of doing something like that guy Fullilove does. Yeah, I'd like to do a public health concentration and name the facility that you're in. And I just want you to remember that you heard it here first. Yeah, please.
Thank you for the talk. Do you have any insight on what your students think are the top concerns or top issues with public health?
Yes, very good. Very concerned about violence and gang violence. Many of my guys are what are called, you saw how good looking those guys are. Those are what we call gangster legends. These are guys who are really bad people in their communities. They almost invariably got locked up when they were 16 or 17, tried as adults. The average length of time my students have been in is 22 years. They've been there a long time. They have grown up literally while they're on the inside. And as they get visits from the community and they hear what's going on back in the hood, what I think concerns them most is how much people think, as I alluded to at the beginning of my talk, being up there with them is the thing to do. Because they are really clear. Nothing could be dumber than to spend 2-3 decades behind bars. So they're very interested in the ways in which turf wars in neighborhoods develop into gang violence. They're very interested in what can be done about that. And they're very interested in issues of obesity. Obesity, yeah. So New York City, Washington Heights, largely Dominican neighborhood, 80% of the adults are overweight or obese. So when mom or the ex-wife comes to visit, and the first thing is, damn, baby, what happened? All the things that you talked about is rude. They're really interested in why no. Why no grocery stores? Why is it so hard? Remember that in the 30s, the face of poverty in the United States was a thin, gaunt figure? Somebody who was emaciated? what is it in 2016? Somebody who's grossly overweight because they're eating terrible food, that in a food desert is all that's available to them, and say, hold on, we got to do something about that. And with so many of these men getting out themselves with chronic diseases that are related to the fact that they have a soy-based diet, cheapest way to feed somebody who's on the inside, they're real clear that, you know, and I've had people write papers on how diet is killing America. Says of all the things, you should never think of HIV as a conspiracy to get rid of people of color. You didn't have to do that. Just feed them the shit that we have in our grocery stores, and it'll do the job. Have we not come out with statistics that suggest that this generation will have a lower life expectancy than the ones that preceded it, literally because of issues related to obesity, chronic disease, and chronic disease mortality? They're really interested in that. Excellent question. Looks like we're done. Thank you.